All right, it looks like everybody's done with their quiz, so if you guys want to come on back into class, we'll get started. All right. So before we get into the PowerPoint and the lecture for this week, I did want to kind of address a couple of things that we ran into when we were grading the discussion post from last week. So while I wasn't here during orientation, I did send in that PowerPoint to you guys on Canvas, but I just wanted to go over our AI policy one more time because we had a handful of students that this was flagged whenever I was reading the discussion posts. Moving forward, every discussion post that you guys are submitting, I am taking what you write and I'm putting it into a chat GPT detector, like an AI detector. So if you guys are using AI to write your discussion post, it's going to flag for me. And that will automatically be a 0 on the assignment. Okay. So moving forward, follow the prompts and everything, but it needs to be written in your own words without using AI or you won't get credit for the assignment. Okay. That is talked about in our orientation PowerPoint because they were running into that a lot last semester with students, and that's a policy that Fortis has adopted. So just moving forward, if you have any questions about that, feel free to message me privately and we can kind of go over that policy again. I had a couple questions about the practice exam. Um, and for the practice exam, you guys are going to need to go into Exemplify. Okay. And then you'll have to look to find Exemplify. You can go into the student resources in the modules, and that should be able to get you to that system that will let you take your practice exam. And as far as like your assignment for the NCLEX, the Saunders questions, if you go directly into module 3, there will be a heading where you're going to be able to see the prompt and which sections you need to submit and complete. It's all going to be detailed for you in the instructions under module 3. Okay. If you have individual questions or you're not able to find it, call me and I can Zoom it with you and show you where that stuff is exactly, but it should be pretty well detailed and explained for you guys under module 3. Okay. Okay, so we have a lot to go over for the PowerPoint this week. So if you guys have it, um, let's go ahead and pull up the PowerPoint and we're going to get started on that. Professor McBride, do you have anything else that you want to add about the practice exam? Because I guess a couple of the students, it's not showing up in their Exemplify on their exam soft.
Let me look real quick and see, because we set it up together, so I don't know why it's not showing. But are any of you able to see it? Has anybody been able to get into it?
I
I had
haven't
to
been able to
email
get
the
in.
dean to
I
figure it
can get
out.
into it, but it's asking for a code.
Yeah,
Okay,
it's
She said
so
for a
Fortis
code.
O 03. And then when
Okay,
I
could,
typed it
could you
in,
repeat it? Yeah.
Fortis O 03, and
03, it should be, Professor
we
Young, didn't we set it as 01?
Um,
said
Let me
O
look at it. I'm
03.
going to pull it up right now. It looks like 7 of you downloaded it.
But a
And
lot of us,
uh,
the dean said that we should know how to do it. But if we're like a lot of us over in Pensacola, we don't use Exemplify. Our tests are either paper, we've done them through Canvas.
okay. So the code should be capital F for Fortis, 01. I don't know if I actually put that to everybody. Hold on. Okay, that should be the code. If you go into your student resources, and let me find exactly where, because the thing is so your exam, this is also why it's good to do this now, because that next week for test day, you're going to need to be able to pull up your exam. And so you need to be able to get in there. So in your student resources, it has, let me make sure it has the information exactly so that you can register for Exemplify. In previous terms, it has been. So I told Professor Young just to refer you to that. Here we go. So I'm actually, if it's okay with you, real quick, Professor, I'm just going to show them this. I'm going to share my screen, okay? So when you go into student resources in your modules, if you look in here, how to register for ExamSoft. Okay, so go to that. And that should tell you everything you need to know, okay? But so the practice code is 4201, and it tells you minimum requirements, use your primary email listed from Canvas, navigate. So you're going to go to, if you copy this link right here, it's going to take you right into the Fortis one. And you won't have to worry about looking for Exemplify or looking for example. Just copy this link into your browser. And then you're going to need to log in using your Fortis email. Okay, and then it'll pull up something like this. Okay, and then it's going to ask you to install Exemplify. And so Exemplify is the app that runs the ExamSoft exams. All right, and so then install Exemplify, and then it'll look like this. Just follow these directions and these prompts, all right, and then you should be good. But it's really important that you all complete the practice exam this week and you go through these steps if you haven't yet to set up these accounts, because next week when you're taking your test, if it's not working, that's going to be really stressful for you. So make sure you take the time to work on that. Okay? Go ahead.
Does each class have its own practice exam? Because we already did a practice exam with another course.
Each class does have their own, and that's a good question. And if you've already done it with another course, we still ask that you do this one, even though it's probably the same thing, okay? And that way, if you have any difficulties on exam day, then we can show that you did the practice exam, and then it's easier for us to navigate if we needed to reschedule your time to take your test later or something like that. So please still do it, even if it's the same thing.
So for my other course, I did the practice exam and we already had exam one last week, but for this class, it's not coming up on my Exemplify at all.
Yeah, it won't pop up on ours if we already took it.
No.
You know what, Professor Young, let me look at it again, because you know what I'm wondering is, you know how we had so many schedule changes? I wonder if some of these students aren't in it. Let me look real quick.
Yeah, because the
Actually,
only exams that are coming up on my Exemplify is for MedSearch.
okay, let me look real quick. And actually, so that we're not delaying class, I can work on this end, and Professor Young can start class. And then I can send out a message in the chat that says, you know, that I was able to fix or not fix or find or whatever. You know what I mean? I don't want this to delay our time.
May I ask just a question? That's fine. But if like you're not able to do it, can we still take the test?
Yeah.
Okay, cool.
You're going to be able to take the exam. The thing is that ExamSoft is a little bit finicky. And those of you who have taken exams in ExamSoft before, they kind of randomly do updates and things like that. And so even if you've been very successful taking your exams in ExamSoft before, you might not know that an update happened that is you're going to need to have due before your test. And so that's why they still have you do this every term with every class. Okay.
Okay, thank you.
And I'm actually looking currently, and it looks like all of the correct all of you are in here. So the other thing that you could do would be to clear your cookies and restart your computer and to try to go in again and see if you see it. Because I'm looking at the class roster for today, and I'm looking at that an example if it looks like it's been assigned to all of you. So sometimes if it's not showing up, you just need to clear it out. So clearing your cookies and restarting your computer might be the trick. And if that doesn't work, then we probably should have you call ExamSoft now and get this all squared away so that you don't have issues on test day.
Okay. I'll restart my computer after class so I don't like disrupt
Yeah.
anything, but
Yeah.
I'll do that.
But Actually, hold on one more second. Oh yeah, no, you're here and you have it. Okay, I was for a second I was like I just looked, but then I didn't see you, but I do see you. You do have it assigned on our end. So do those steps after class and then reach out to Professor Young or to myself. I'm listing your Canvas as well. And we can work on it if you're still not seeing it.
Okay, thank you.
Okay.
I have a question.
Yeah.
Just to confirm, if I go into Exam Soft and it pulls up as two classes for like MedSurg and this course, am I good or do I have to still follow those steps?
If you have it already, you don't have to follow the steps. That was for the Pensacola students that were saying they haven't had to do it before and they didn't know how to access it. If you know how to access it and you can see your stuff, you're good.
Okay, thank
Let me just pull up my PowerPoint really quick. My computer kind of froze on me, so give me a couple minutes here.
Sorry, one more question. So if it's pulling up with the two classes, we don't have to do that quiz you were talking about, or it's the practice quiz was already for you to get onto the exam soft.
Please do the practice exam. Yeah, so still do it. You don't have to do the steps that I showed you in the student resources because you're already in. And even if you've already done the practice exam for another class this term, please still do it so that we can show that it was completed, just in case there's any difficulties on exam day, okay? It should only take a few minutes to go through the practice exam. I lost you, Yvonne. Did you hear what I said?
I'm sorry, I'm still here. It's just echoing. But yes, and can you send out where that practice? Because I was just able to go straight to the website, but I can't find the practice test. Sorry.
Yvonne, since yours is on a Mac, me and Danielle, when we did ours, you should have a little blue check with three lines at the bottom where your bar is. And then when you click that, it'll come up. We can FaceTime later and I can show you where it's at. Okay.
So, Faith, say that again. Where was it? Because that's
So
helpful for me to know
me
too.
me and Danielle, who's in here, we spent like literally over an hour trying to figure it out because we've
Yeah.
never done this before. And once you go to the link, you sign in and everything like that, it takes forever to get to it. And then if you're on a Mac, it'll show like where your Finder and your Safari and your FaceTime and all of that is at the bottom. If you click where there's like three lines with the check, if you click that, it'll pull up the practice exam and it'll say begin.
Oh.
And it'll it would only work for me on Chrome, not
Yeah, it has to be
Safari.
through
Oh,
Chrome, not Safari.
that is an important detail that I had forgotten to mention. Okay, guys, that is an important detail. So you can't run software Exemplify through Safari on your Mac. You need to run it through Chrome. I'm so
Right.
glad you guys said that.
I have it pulled up. I'm using Chrome and everything, but it still is not allowing me to click on the practice exam. Do
Maddie,
I?
I'll help you guys after
Okay.
because you both are on Macs and I had to help Danielle navigate through it. So I got y'all.
Okay,
It's
thank you.
it's a pain.
It is.
I'm so glad to know that not only that we have faith that can be helpful, but also to know that there's these extra steps on a Mac. So thanks for sharing that helpful information. And that might be true also for Caitlin, who wasn't able to see hers also. She might also be on a Mac.
I am, and I'm like following as she's talking.
So there's a lot of information also for class today. So maybe on a break or at the end of class, you guys can work on this a little bit more. But it looks like Professor Young got her PowerPoint pulled up, and so there's a lot to cover today. So maybe we'll jump into week 3 concepts and then work on practice exam later, if that's okay.
Right. Does anyone have any like really quick questions? But if not, we're going to just go ahead and jump into this because we do have a lot to cover today. Alrighty. So mainly today we're going to be talking about labor and the birth process. So this is going to include a lot of different topics. And I'll have a lot of good information for us. So we're going to start with talking about labor and the birth process here. So there are some factors that are important to note whenever we're talking about labor, things that are going to affect labor. So when you're thinking about it and you're looking at the anatomy, we're going to talk about the size of the fetal head. Obviously, this is going to be a big impact on delivery, on labor, and how long the labors are. So one of the main things that we're assessing whenever we're assessing fetal head is the location of the sutures and fontanelles. So it's important to also know what sutures and fontanelles are, right? So sutures are the connective tissues that are connecting the bones of the fetal skull. Fontanelles are the area where 2 or more of those bones are going to meet. The 2 most important fontanelles that you guys probably hear about a little bit more are your anterior and your posterior fontanelles. The anterior fontanelle, which I have a picture down here in the center here. Your anterior fontanelle is that diamond-shaped one that closes about 18 months after birth. Your posterior fontanelle is the triangle-shaped fontanelle that closes 6 to 8 weeks after birth. Some people refer to these as soft spots. Whenever you're assessing a baby, you're going to be able to feel them. And when we talk about newborn assessment later in the term, we'll go into it in a little bit greater detail. But these structures of the fetal head are really important because sutures and fontanelles are what makes the skull flexible for birth, and that allows for molding, which is when the baby's head kind of shapes to the vaginal canal and allows for the baby to come out and have a smoother passage through birth and into the birth canal. Because these bones are not formally united, the slight overlapping is going to occur, which is that molding. So knowing molding and knowing what that means is going to be important. You want to know what that is. Yeah, basically it just helps adapt to the size of the maternal pelvis. So down here, these pictures kind of show you suture lines, fontanelles, and then it also gives you a good example of like molding. So you see the baby's head, how it's kind of a cone shape. So whenever you guys are doing your clinical, or sometimes you just see this if you guys have had children, sometimes babies will be born with that cone head. That is normal, and it usually goes away even in a couple hours, depending on how long the labor was and how much compression that fetal head was feeling during delivery. So another important thing to talk about is fetal presentation. So the main ones are obviously cephalic, when your baby's head is down, and that's the presenting part, and that's what's being delivered first. Other ones that we can see is breech, which there's a couple different kinds. I don't go into too much detail on these slides about it, but breech, you can either have the baby's butt coming first, the baby's feet coming first, or a mix of both. So this is slightly different than the presenting part. So fetal presentation is a little different than presenting part because the presenting part is the part of the fetal body felt first whenever you're examining a cervix, right? So whenever you are examining a mom, she's in labor, you're using your fingers to kind of feel her cervix and feel what is the presenting part. So feeling either baby head, baby butt, baby foot, that would be your presenting part. In your cephalic presentation, you're typically feeling like occiput, which is part of the baby's skull. Breech would be a sacral presentation, so those are just like the terminology whenever you're describing it, or whenever you're charting it would be the example. Um, obviously, what would be the most ideal presenting part? What do we want? This might seem like a pretty straightforward.
Head.
Yes, you want your baby's head to be down. We are not, and right now, like doctors, and it's not common practice to deliver breech babies vaginally. Unfortunately, I've seen it happen in an emergency, and it was one of the scariest things in my entire life. But um, they're not teaching that in med school. We're teaching vertex vaginal deliveries. So you want an occiput vertex cephalic presentation. Okay, that's going to be the most ideal for the birth. All right. Sorry, my presentation is being all weird right now. All right, so moving on also to the factors affecting labor passengers. So a couple other things that we're going to be assessing whenever we're doing a vaginal exam or a cervical exam will be your fetal lie, your fetal attitude, and your fetal position. So all of these things are being assessed by how the baby is laying in the perineum and how the baby is descending through the vaginal canal. So your fetal lie is the relation of the fetal spine in relation to the mom's spine. Okay, so your most common ones I have listed here are longitudinal, vertical, transverse, horizontal, or oblique. Your most common one, and the one that we prefer that's ideal for labor, is longitudinal or vertical, which that is like when baby's head is down and they're in an appropriate position for delivery. So if you have a transverse lie, that means baby's spine, baby's laying completely sideways in the uterus. So would mom be able to deliver that way vaginally? No. So anything like the transverse, the horizontal, or oblique lie, that is not something that's going to be ideal for labor or for the delivery of infants. So those kind of presentations, you'd be able to tell because you would go in to examine the mom and you would either not feel a baby's head or her belly would be super misshapen and there'd be other signs like clinical signs that the baby's in a really weird wonky position. Okay. Your fetal attitude is the relation of the fetal body parts to one another. So let's see, I think I have one of those pictures down here. These pictures down here are showing you presenting parts. And then the second picture is showing you like fetal attitude, lie, position. So your fetal attitude, the normal one that we want to see is general flexion, which that's when the back of the fetus is round. So the baby's kind of curled up. The chin is flexed down on the chest. The thighs are flexed up onto the abdomen. And then the legs are kind of flexed at the knees. The baby's arms are going to be kind of crossed and tucked in. And then the umbilical cord is going to lie between the arms and legs. So this is the ideal position for birth because it's baby's like scrunching up and getting in a good position so that when those contractions are happening, it's pushing the baby down onto the cervix, but the baby's not like the one arm isn't like sticking out through the vaginal opening. The foot's not like doing something wonky. Like the baby's tucked in, being squeezed appropriately. And ideally your umbilical cord is out of the way. That way it's not being compressed too bad during contractions. Okay. We're going to talk about fetal tracings and abnormalities with fetal tracings later in this PowerPoint. And you'll see that the location of the umbilical cord in relation to how the contractions are happening and where it's being felt. You'll be able to see that on fetal tracings because your baby is going to show signs of distress with some of this stuff. But what I want you to take out of this is the best fetal attitude would be general flexion. That's going to be the most ideal for a good vaginal delivery. Okay. So your fetal position is kind of divided into three different categories. You're looking at the baby's position, the station, and engagement. So your position is the relationship of a reference point on the presenting part to the quadrants of the mom's pelvis. So your first letter, this fetal position is described in three different letters. So your first letter notes the location of the presenting part, whether it's on the right or the left side of the mom's pelvis. So that's going to be an R or an L. Your middle letter is going to stand for presenting part of the fetus. So if it's occiput, which is our ideal presentation for the labor, it's going to be O. So if baby is on the right side of mom's pelvis, that's an R. If the presenting part is occiput, that's an O. And then your last letter would stand for the location of the presenting part in relation to the maternal pelvis. So is baby anterior? So are they upright at the cervix and the pelvis? Are they posterior? Are they tucked back a little bit? Or are they transverse, which we don't want to see? So that would be, say, baby's on the right side of mom's pelvis, so R. Occiput presentation, that's O. And then baby is posterior, that's P. So you would be putting in ROP as your assessment of the fetal position. Okay. So
Excuse me.
yeah.
Can you make it a little bigger so we can see it? It's
Oh
very
yeah.
small.
Let me try. Let's see if I can. Is that a little bit better?
Just a tad.
Yeah, it's like my PowerPoints are being super weird right now, so I apologize. But let's see. So I'm kind of flipping back and forth between two screens here, but
Her PowerPoint is also uploaded in the instructor material under week 3, so you could also pull it up, or it might also be in your announcements if you want to follow along that way.
Okay, thank you.
alrighty. So kind of moving on, your station is going to be the relationship of the presenting fetal part to kind of an imaginary line that's drawn between the mom's ischial spines and her pelvis. So this is measuring your degree of descent through the vaginal canal. Okay. So for example, which I have this on the next slide. Let me pull it up. It'll be easier to kind of tell. So here you can see those ischial spines, that would be 0 station. Okay. If the baby's head is up further, like the baby hasn't descended as far down the vaginal canal, you're looking at -1, 2, 3, 4, 5. -5, like you will not be able to feel that fetal head. That baby is in no man's land. We do not know where they are because you will not be able to feel that. Pretty much with your fingers, with like a vaginal examination, you're going to be able to feel baby's head when they're like -3. Anything above that, we would call that like bellotable, like you can't even tell where the baby is in the pelvis. So baby is not engaged at all. Whenever baby's head reaches those ischial spines and is engaged in the pelvis, that would be 0. And then you're going +1, 2, 3, 4, 5. Basically 4 and 5, that baby's head is almost like you're crowning. Your baby is going to be delivered. That's imminent delivery. Okay. So this image kind of shows, you can even see this little like baby head coming down through the pelvis. And that is how we measure our station when we're doing vaginal exams. Let me go back. So the last thing that we really want to talk about whenever we're talking about fetal presentation and stuff in the vaginal canal during labor is engagement. So if the fetal head is engaged, it's applied to the cervix and present in the pelvic cavity. Fetal engagement, it does not necessarily happen only when mom is in labor. This is something that can happen like weeks leading up to delivery. So moms can say like, oh, I felt baby drop, which means they felt a lot more pressure in their pelvis. The baby's getting a little bit lower. That's sometimes a sign that the mom might be experiencing labor in the upcoming weeks. But then again, as you guys may even know, like some women just naturally will carry their babies lower. So their babies could be sitting on their pelvis like that for months. But we do look for engagement because say a mom comes in for an induction, you're not going to start an induction if your baby is -5 station out in no man's land. You can't feel what the presenting part is, right? A provider would have to come in, verify vertex and cephalic presentation, and need to make sure like baby's not in like a transverse lie or doing something weird like that before we give them medications to speed to put them into labor. That would just be very unsafe. So down here, I kind of have some pictures too of the fetal lie, attitude, and position, and some couple examples of different presentations of fetal part. So that this one over here, this footling breech, this picture on the left side with that baby's foot sticking out, that baby, like that, you would be delivering cesarean, and it would be an emergency because you have a presenting part that's like hanging out of the vaginal canal, right? This isn't something that's like, oh, we'll just wait and see kind of what happens. It's like, no, we're going to go back and have a C-section. So this over here too, this picture shows a good example of a transverse lie, where the baby is laying sideways in utero, which is another thing that we would be doing a C-section on. You're not going to deliver that baby vaginally. So after talking about baby and their role on labor, we're going to talk about mom's anatomy and things that are going to affect the passageway as far as on her anatomy and her side of things. So your pelvis is made up the pelvis, cervix, vagina, soft tissues, and the pelvic floor. Your shape and size of the pelvis is sometimes determined at your initial prenatal visits. And this is kind of the provider's way of assessing the success of the labor process. And if labor is something that is going to be compatible for this mom and just like the way that her body is shaped. There are 4 different shapes of the pelvis, which we kind of went over last week. The gynecoid, android, anthropoid, and platyploid. What is the most common and favorable? Which one is the one we want to see? You guys remember?
The gynecoid.
Yep, you got it. So your gynecoid is the most common, and that's the most favorable pelvic shape for a successful vaginal delivery. So you guys are definitely going to want to know that. That's going to be important to know when we're talking about pelvic shape and size. Soft tissues of the vagina play a major role in labor. So when you're doing a vaginal exam, the cervix is what we're assessing and feeling to determine a patient's dilation, which is the opening of the cervix, and then effacement, which is the thinning of the cervix. Okay, you need both dilation and effacement for moms to be able to successfully have a vaginal delivery. Your contractions cause the fetal presenting part to press down onto the cervix, which causes changes in the dilation and effacement. Without contractions, that baby's head isn't pushing down onto the cervix, so labor is not happening. That baby's not going to be able to come out. So you really do need strong, consistent abdominal contractions to push that presenting part down on the cervix, and it causes it to thin out and dilate. Your effacement is measured in percentage. 0% effaced means that cervix is not thin at all. Like it is completely thick. 100% would be it's paper thin, you barely can feel it compared to the baby's head. Okay, so 0 is very, very thick cervix. 100% is a very thin cervix. And then your dilation is measured in centimeters. So 0 centimeters to 10 centimeters. 0 centimeters means your dilation is, you don't have any dilation, it's closed. Your cervix is closed. And then 10 centimeters is the cervix is completely gone away. That baby's head is the only thing you can feel, and delivery is going to be pretty quick after that. So I have a practice thing here. A woman comes to the hospital after she's been examined in the office. Her vaginal exam says that she is 6 centimeters dilated, 80% effaced, and 0 station. If you're a nurse and you feel that, what do you think that means? What should you be getting ready for?
C-section.
Delivery.
Yeah, you're going to be getting this mom admitted for sure. Like she comes over from the office and that's her exam. You're going to want to get her admitted and get her into a labor room because she is definitely in active labor. So she's going to be staying and having her baby. So this slide, I have a couple pictures here that should hopefully help kind of with the dilation and effacement thing. So over on the left here, I have this cute little dilation chart that shows the different sizes and shapes of cervical dilation from 1 centimeter all the way to 10 centimeters. And then on the right is a little graph showing cervical effacement. So you can see on the left that that cervix is not effaced, or there's really no dilation. So you see how thick that cervix is still. There's a lot of cervix that's in between the baby's head and that vaginal canal where they need to be coming down for birth. And then on the right, a cervix that's fully effaced and completely thinned out and all the way gone. So baby has nothing standing in the way of delivery. So another thing that affects the labor and delivery part is some what we call powers. So we have primary powers and secondary powers. Primary powers are like your contractions, okay? Your contractions are responsible for dilation, effacement, and then fetal descent. Certain external factors are going to change the effectiveness of this stage, okay? So if you're thinking about it like from anatomy standpoint, what are some things that can affect your contraction pattern? What are some things that could affect like how your baby is descending? Just kind of thinking critically. There's really no like whatever you guys think. I just kind of want to hear what you're thinking as far as this goes. There's a couple here listed for you already.
Say the question again.
So like what are some things like that you think affect contractions and the effectiveness of contractions?
Maybe stress level?
Yeah.
Breathing patterns.
Yep. How the mom's handling her labor could be.
Fetal position.
Yes. So like we'll kind of talk about the ones I have listed here too, because they're pretty big ones. So your fetal position. So if you have a baby who's breech, right? And it's a soft butt that's being pushed against that cervix, is there going to really be that much effective cervical change? It's a soft presenting part. So it's not pushing down super hard on that cervix. If it's just a foot, it's only going to dilate a certain amount for that foot and then it's going to stop, right? Another thing that could affect it is if your baby is posterior. So that baby's spine is in line with mom's spine and the baby's eyes are looking up at mom. Like when baby's being delivered, we call that sunny side up. Baby's eyes are the things that you see when the baby's coming out. That is not an ideal position for labor. While baby's head is down, the head isn't aligned as well with the cervix. So that's where you see like an irregular contraction pattern, a long labor. So the mom might have a couple more contractions, but they're not as effective because that baby's presenting part isn't pushing down as effectively on the cervix, right? If a mom has had, like, say she had an abnormal pap smear and she had to have a LEEP procedure done, which is when they take a little ring off of the cervix to have it biopsied, whatever. If they have any kind of like scarring on their cervix, that's going to delay your contraction. That's going to delay your labor as well because that cervix has scar tissue. So dilating and effacing a scarred cervix is going to be a lot harder than one that isn't scarred. Okay. And then however many babies the mom has had, right? If this is her first baby, you're anticipating an average 24-hour labor. Average for a first time mom, right? Some are longer, some are shorter. But if it's a mom who you know is coming in hot and she's had 6 babies, her labor and her contractions are going to dilate her cervix much quicker. Okay. So those are some examples of primary patterns and how the uterine contractions are going to be affected by mom's anatomy. Your secondary powers come later in labor, and that's your maternal pushing. So that is that really strong urge that women can't resist whenever they get so far into their labor. They're fully dilated and they're like, this baby's coming out now. I need to push. And they will say that, like, I cannot stop. I have to push. And that is their secondary power kicking in, helping them deliver this baby. All right. So, some signs that are preceding labor. So, things that moms sometimes experience before their body goes into labor. There is a good table for you guys on page 327, box 31.1. But here are some examples. So some lightening, they might have some return of urinary frequency. They might be experiencing backaches. They are having stronger and more frequent Braxton Hicks contractions. They might lose a little bit of weight because they might be a little bit nauseous again and start having like kind of first trimester symptoms. Some women have that surge of energy, which some people will call like nesting, where they just are like, I need to clean my whole entire house right now. They'll have increased amounts of vaginal discharge, cervical ripenings. Their cervix is getting softer, more pliable, ready to have some change happen for labor. And then their water might break. Possible rupture of membrane. That's what ROM means whenever I put that in there. So if their water breaks at home, having really good education with a patient on like, okay, this is what it looks like. Because some people will come in and they'll be like, my water broke. And like they actually like just peed their pants a little bit, which happens a lot. And it's not something that is like, embarrassing. Like it does happen quite frequently. But giving them really good education on what it looks like when your water breaks, things that we want to know. Like if your water breaks at home, we want to know, what is its color? Like what does it look like? Because if it's green, we definitely want to know that, because that's meconium, and that puts the baby at a higher risk for any complications after delivery, right? Is there an odor to it? Because that way we're assessing like, could this mom potentially have choreo, infection of the amniotic fluid develop? So color, odor, and how much fluid are we losing? So did the mom have a ginormous gush to the point that it was completely soaked her bed sheets, or was it just a little trickle? So all things that we want to be educating our patients on. But these are some signs that the mom might kind of report before she goes into labor. All right. So getting into stages of labor, we go into this a little bit more in detail whenever I talk about the, excuse me, the fetal heart rate tracings, whenever we go into that. So labor defined, move some things. I can't see things really well right now. All right. Labor is defined as regular progression of uterine contractions. And then you also need to have progression of effacement and dilation and progression of the descent of the presenting part. Okay. So if a mom comes in and she's like, I think I'm in labor, I'm having contractions, I'm 37 weeks, we're going to be putting her on the monitor. But she could be having contractions. But if she's not making cervical change and she's not dilating or having any like thinning of her cervix, and that baby's head isn't coming down, then she's not in labor. We can give her something to help maybe slow her contractions down or to relieve some of her pain. But we need these three categories here to make it official. Like, yes, you are in labor. And then so once we get into labor, you're talking your first stage, which is the onset of regular contractions until you get to full dilation. This is the longest stage of labor, and it's divided into two stages, which we call latent, which is early, and active. During your latent stage of labor, there's usually more progress in effacement of the cervix, but the baby's head isn't coming down. So you're in your first latent stage of labor, your cervix is thinning out the most. That's when you're going to see the most thinning of the cervix. But your fetal head might not be coming down, and you might not be having an insane amount of dilation of the cervix. Okay. In your active phase, the descent of the fetal head and your dilation of your cervix are going to happen more rapidly. Okay. So in that active stage of labor, which we typically call a mom active when she's 6 centimeters or greater, that mom might be changing her cervix every hour or faster than that. Okay. So those are those two stages. Your second stage is defined as when mom is fully dilated through the pushing to the delivery of the infant. Your third stage is the birth of the infant until the delivery of the placenta. And then your fourth stage is the recovery period. Okay, so that's when we're monitoring mom and baby and looking at their vitals pretty closely and making sure that they're both doing well. Like I said, we're going to kind of go into these in more detail whenever we talk about fetal heart rate tracings, because different things can happen with your tracing at different periods during the first and second stages of labor. So I wanted to talk about that a little bit more too. Everyone doing okay so far? Any questions? So, kind of going into our mechanisms of labor. So, things that we really want to see is your engagement. So, how the baby's head is coming down, if baby is being engaged in the pelvis and onto that cervix. Something that is important to know about is asynclitism. So, this is what happens when your head is poorly positioned for a bad descent through the pelvis. This will cause, kind of like what I talked about when we were talking about primary powers. If that baby's OP, so the baby's facing up, this can cause long labor, irregular contraction patterns, and then cephalopelvic disproportion. Okay, so that baby's head is not pushing down on that cervix equally, and it's called that's what we call asyncliticism. You might hear people say that baby's head is asynclitic. That's usually how it's described, at least when you're working on the floor and you're in at bedside. So an asynclitic presentation of the fetal presenting part is going to cause a longer labor, irregular contraction pattern, and it's just going to prolong everything. It's going to make everything a little bit more challenging. We also want to see descent. So descent is referring to the progress of the presenting part through the pelvis. Some factors that can impact your descent would be your pressure that's exerted by your amniotic fluid with contractions, the direct pressure of the contracting fundus on your fetus, and then your force of contraction in the second stage of labor. Okay. This is measured, you measure your descent based on your fetal station. So where that baby is in the pelvis. Okay. We were talking about those degrees of measurement. So 0 station, -1, -2, that's what is kind of determining your descent. Your flexion is, it's a description for the baby's fetal head. So your fetal head typically flexes, so the chin's brought down onto the chest. And then also we're looking at internal rotation. So this would be your baby's rotation with the contractions. So whenever we're having a contraction, a baby is going to naturally rotate through the vaginal canal, which is hopefully rotating into an optimal position, right? Not an OP position or something that is asynclitic. But your baby is going to be doing some rotating because they're going to be moving and kind of adjusting to the contractions and adjusting to the labor as well. You're looking at extension, which occurs when the fetal head reaches the perineum for birth. So that is what happens when we kind of like when baby's being born. You see the baby's occiput come first, then the face, and then the chin. So that's how the baby should be coming out, which you can kind of see in that picture D on this graph is that that baby's head coming out first occiput, then the face, then the chin. And then your expulsion obviously is when the baby is completely born. Okay. Alrighty. So there's a lot of things that are happening whenever we're in labor, whenever moms are in labor. First thing that we're looking at was the baby and their physiologic adaptation to labor. So the number one thing that we're monitoring throughout an entire labor is the fetal heart rate. What is your optimal fetal heart rate? What is your normal?
It's like 140 to 160. 160.
So it is to 160. It is as low as 110. So 110 to 160 would be our normal fetal heart rate. Okay. Something to note about during labor, sometimes your fetal heart rate will decrease as an infant grows closer to term. So in labor, which we'll talk about fetal tracings here in a couple of minutes, you're watching the baby's heart rate, and that can change throughout labor for a lot of different reasons. We'll talk about some of that a little bit later in the presentation. The other thing we're noting about the fetus is the circulation. So the circulation of the infant is impacted by uterine contractions and the stress that they're put under during labor. So if a baby is in distress during labor, usually what causes that is umbilical cord compression. If they're having any like issues, you see that, and that's usually because the umbilical cord is being compressed. Okay. The really big one that we want you guys to know is the respiratory system and how it changes. Okay. So the baby up to this point has not breathed oxygen. right? The baby is not breathing oxygen in utero. So what we need to know about once after delivery is that fetal lung fluid is going to be cleared from air passages as the infant passes through the birth canal. The oxygen concentration decreases, arterial CO2 increases, arterial pH decreases, your bicarb level decreases, and then your fetal respiratory movements decrease during labor, right? So their body is making that transition to be able to breathe on its own, to be able to convert oxygen and carbon dioxide. Like it's going to be completely changing its mechanisms as the labor is progressing to prepare itself to be able to breathe oxygen and breathe on its own. Something that I wanted to mention is when the baby is coming down through the vaginal canal during birth, they're being squeezed so hard that that helps expel that fluid, the amniotic fluid or anything that they're ingesting on their way down through the vaginal canal. And that pressure that's being exerted from contractions in the vaginal canal during labor is helping them clear out their lungs so that they're able to breathe a little bit easier. That is why sometimes you'll see C-section babies have a harder time and they might be a little bit gruntier. They might have lower APGAR scores. Their respiratory rate might not be awesome at delivery because C-section babies aren't getting that squeeze in the vaginal canal during birth, right? And that's a huge physiological advantage for vaginal deliveries is that squeeze and pressure that's being put on the infant to help them expel that fluid, okay? And then obviously moms are going through a lot of different things with labor as well. So their cardiac output is going to increase in the first stage of labor and even more in the second stage. Their heart rate is going to increase. Their blood pressure will increase with the contractions. Why? Because they're in pain. Okay. If they have preeclampsia or underlying hypertension issues, that's going to be exacerbated in labor because of all the stress and all the hormones that are being released during labor. Okay. You're going to see an increase in white blood cell counts. Their respiratory rate might increase, which is why we're so important as bedside nurses, because we need to be coaching moms on that slow, deep breathing. Otherwise, they could hyperventilate, and their risk for fetal metabolic acidosis is going to increase if they're not getting oxygen to the placenta, right? Their temperature might elevate in labor naturally. If their temperature is elevating too much, that could be a sign of chorio or any other type of underlying infection, which is something we'd want to let our providers know. They might have some protein in their urine. A little bit is okay whenever you're in labor. That can be like a stress response. However, if you have elevated protein in your urine, that's something that could be indicative of preeclampsia and would be something we would need to closely monitor. Gastric motility and absorption of solid food are decreased. A lot of hospitals don't let women eat when they're in labor. They keep them on clear diets. Okay, I worked for 2 different labor and delivery units. One of them allowed moms to eat in labor, and the other did not. Do you guys know why they wouldn't want moms to eat during labor?
So you don't have to give them an enema, or they won't poop.
So more
Is
of
it because they have to may have to have a cesarean delivery?
Yes. It's more on the off chance, like if they want an epidural or any type of anesthesia providers do not want their patients to eat. Like even for an epidural, because sometimes epidurals will drop your blood pressure, right? And make them hypotensive, which can cause them to get really sick and vomit. So we don't want to run the risk of them aspirating. Okay. So that's why they're usually kept on clears because we don't want them getting sick during any anesthesia that they might have. Nausea and vomiting is common. Their blood glucose level is going to decrease. That could be because of the labor process. It's also because they're not getting an adequate intake during this time. And then, like I said, the biggest thing that we need to know, and especially as nursing staff, is coaching them through their contractions and encouraging those deep breaths to preventing them from hyperventilating. Alrighty. So this is a huge part of nursing care is making your laboring mom as comfortable as possible. And that can look a lot of different ways for a lot of different moms. So a lot of factors are going to impact a woman's pain during labor and delivery. Their perception of pain, right? A 10 for me might be a 2 for Alexia, right? It's everybody's different. So we need to be assessing pain. That's something that's going to be huge as part of your vital signs assessment is how they're doing. Their expression of pain. When I work with the Amish patient population, a woman could come in and be completely dilated, 10 centimeters, and you would not even know. Like you would think she was just in Walmart getting her groceries. I promise. Like it's sometimes really hard to tell. So you got to ask them, constantly be asking them how they're feeling, how they're doing. Culture will play a big part of it. Same with like the Amish, like I just said, they're an extremely stoic culture. They're not going to express pain the same way that I would. So keeping that in mind whenever you're taking care of these patients, that just because they may not be acting the way you would during pain does not mean their pain is not at an intolerable rate. Anxiety. If a mom has high anxiety, her pain level is going to be greatly impacted. Previous experience. If a mom comes in and tells you that she had the worst labor experience of her entire life, that it was traumatic, she ended up having an emergency C-section and had to be put under general anesthetic and all this crazy stuff from a past delivery, that's going to affect her experience with her next one. She's going to come in and be a lot more anxious. She's going to not know how she's feeling. Like she might not even have labored with her last delivery, so she might not even know what to expect. So we're educating and we're monitoring and assessing. What does your patient's support look like? Do they have a partner or family that's at the bedside that is hands-on helping them with their labor? Do they have are they by themselves? This is going to really impact their experience and their pain level as well, how they're handling it and who their support is. A big thing we're seeing, especially like currently, has been a lot of different birth plans and preferences. So a patient, if they bring you a birth plan, we are respecting that birth plan. We are reading it. We are making sure that to the best of our ability, we can accommodate this. Okay. However, we're still being realistic, right? Like you have to do what's safe. You have to follow hospital policy. So if your hospital offers tub births, knowing what kind of mom is allowed to have a tub birth, right? So at our hospital, you can only have a tub birth delivery if you have no other risk factors in your labor and if you aren't getting induced. Okay. So I had a mom come in who was a chronic hypertensive patient who was getting blood pressure checks every 30 minutes, and she was no longer a candidate for a tub birth, and she was really upset because that was on her birth plan. So really educating with the patient and trying to help them adapt, like maybe that means they could get in the shower for 15-minute increments, helping them kind of come up with a solution that fits their birth plan while also being safe, because safety is the number one priority. And then their environment. So it is important as the nurses to maximize the comfort of the environment in a hospital, right? Nobody really loves being in a hospital, even for happy things like delivering a baby. So that means like we're dimming the lights for the patient. If they want aromatherapy, we're getting our diffusers out. We're going to make sure that there's not as many people in the room if there doesn't need to be, right? Like this is not like show and tell. If a patient says they don't want a student in the room, we need to respect that. Okay. So the biggest thing is we are not here to pass judgment on our patients. We're here to support them. So that is a big part of the labor and delivery process. So kind of moving into that, we're talking about pain management. So some non-pharmacologic pain management interventions. This is really good to know because if your mom says she doesn't want any pain meds, I don't want an epidural, that doesn't mean, okay, I'll see you whenever you're ready to push. There's other things that we can be doing. So relaxation and breathing techniques, counter pressure. So that means like if the mom's having insane back pain, pushing on her hips, maybe helping her to a different position where she can have that counter pressure applied to help relieve some of that pain. Application of hot and cold, acupressure and acupuncture. With these, the biggest thing is knowing your hospital policy. My hospital, we don't do acupuncture as RNs. Like if they have somebody that comes into the room with them and wants to do it, as long as they know that they're confined to their medical allowance, like whatever, you can. But as nurses, like most of the time, we're not the ones doing that. Application of a TENS unit, right? That's a really big one that we see a lot. Hydrotherapy, aromatherapy, music, hypnosis. Position changes is huge. Okay. Like especially if a mom's wanting to go naturally, even when a mom has an epidural, you can be changing their position. So like common ones are like hands and knees. You can use like squat bars, birthing balls, peanut balls. That's kind of down by those birthing tools, like a mirror. A really good company, like especially if you guys do end up going into labor and delivery and that's where you want to practice. A really good company is called Spinning Babies. And they have like a whole bunch of different types of exercises that moms can do even before they go into labor that help like optimize labor and get their bodies ready to deliver. And they have a lot of stuff for nurses that you can use as well. So it wouldn't be a bad idea to check them out because they have some really cool stuff. All right, let me see. My PowerPoint will listen. All right, there we go. All right, so pharmacological pain management is a little bit different and there's different stages depending on like what the mom is wanting. Okay, so this is all going to be patient preference really. So there's different classifications. So the first would be your sedatives. This is going to relieve anxiety and promote sleep. These are not going to produce any provide any pain relief, right? So like your Ambien, Phenergan, Reglan, Valium. This is a really great option early in labor or overnight if they have like a late induction start. Sometimes these can be combined with certain pain medications to enhance the effects of the pain meds and just like help the mom relax a little bit better. You have to be careful because these meds can depress the central nervous system, which could potentially cause respiratory distress in both mom and baby, right? So just like make sure you're doing all your checks on your MAR and administering it properly. So if you know that, like obviously as a nurse, you're going to put on a pulse ox on your patient so that you can monitor them continuously, right? And you want to have a reversal at the bedside if appropriate, depending on what you're administering. Nitrous oxide has really gained popularity, especially this year. I feel like I've done this a lot with patients. This is your laughing gas. It is an inhaled anesthetic. Usually the way that it's administered is in a 50-50 mix with oxygen, using like a blender device, and it's held by the mom. That is usually one of the number one things that you want these patients to know is partner cannot hold that mask for them. This is kind of like a PCA, right? Like nobody's supposed to be pushing that button for the patient. Nobody's supposed to be holding that mask for the patient with the nitrous oxide. The mom needs to be the one to do it. That is important to know. Let me see. Nitrous oxide, it's not going to completely remove your pain, but it will decrease the intensity. Some things that you need to know about this is that it'll cause nausea and dizziness. So you want to keep your mom in bed or at least sitting somewhere. You don't want them up moving around in the room while they're using nitrous oxide or really any of these interventions at all. Let's see. And then if you know that this could potentially cause nausea, sometimes prophylactically administering an antiemetic isn't a bad idea, right? So giving them some Zofran before any of these meds might be a good idea for them, especially if they have a history of hyperemesis, right? Like if you know they're going to be uncomfortable with these meds, like might as well treat the nausea before it even starts. Moving on to your general anesthesia. This is not used in an uncomplicated delivery, okay? If your mom is under a general anesthetic, she is back for a stat C-section, okay? General anesthetic is used for maternal or fetal distress. So if you have to have that baby out now, you're doing a stat C-section, you're putting the mom under general anesthetic. Babies must be delivered immediately when the mom is put under general. So usually the anesthesia provider waits until the mom is completely draped, the belly has been scrubbed, and everybody in the room is ready to receive that baby, because once that mom's under general, her central nervous system is depressed. Baby is not receiving a lot of oxygen, and that baby needs to be delivered right away. Okay, so you do not see this unless there's an emergency. Your nerve block. So the most common with this is like a local anesthetic, which we're using for perineal repairs after delivery of the infant. So that's like lidocaine if a provider has to do a perineal repair. A pudendal block, I'm probably not saying that word right. I even practiced it, but may be administered late in your second stage of labor. This is mostly for if we have to cut an episiotomy. Okay, so it's a little bit bigger of a syringe of a needle, and it's going a little bit deeper into the perineum because if a provider has to cut an appease, whether like we need to get that baby out quickly because they're in some distress and we're vacuuming the kid out in a hurry, or mom is tired and maternal exhaustion and we need to cut an episiotomy to help her with the delivery, this is the kind of block that you're going to be looking at. It's just a little bit deeper of a block. A spinal is an anesthetic solution containing a local or containing local combined with an opioid agonist. It's injected lower in the spine in your lumbar space. And this can be used for vaginal birth, but it's not suitable for labor, right? So you're not running a spinal continuously. This is a one-time dose of medication. Commonly, you can hear it referred to as like saddle block. So if a mom is like pushing and something has stalled, she's pushing for a long time, her pain medicine, she's in a lot of pain. Anesthesia providers could sometimes do a saddle block. You really don't see this very often because most of the time at that stage in labor, most pain medication is going to be pretty ineffective, right? You get to a certain point in your dilation and a lot of the pain medicine isn't going to be effective at all. So you're not seeing spinals as often. You see spinals with a scheduled C-section or if it's a non-emergent C-section rather than an epidural or a general. Spinals are for the C-sections. And then obviously we're going to talk about our epidurals. So this is your golden choice, your most common choice during labor. It is bupivacaine or ropivacaine injected into the epidural space. This form of medication results in the least amount of CNS depression, so it reduces the risk of fetal respiratory distress or maternal respiratory distress. So as a nurse, the things that we need to know is like, how are you going to position your patient for these? So your patient should be sitting on the edge of the bed, kind of hunched over, like we call it like a cat, like sticking their spine out towards the anesthesia provider. You could stand in front of them, kind of hold their shoulders and help them get in that position. They should tuck their chin to their chest. Another important thing I want you guys to know is one of the biggest side effects of an epidural is maternal hypotension. So you're going to see mom's blood pressure tank sometimes with epidurals, especially if your anesthesia provider gives them a really strong, good epidural. Their blood pressure could tank, and then we need to administer ephedrine, okay? That is the reversal for that. That's going to bring the mom's blood pressure up, dilate their blood vessels, and increase their blood pressure. What do you think baby is going to do if mom passes out? What are you going to see?
Wouldn't the fetal heart rate bottom out too as well?
Mm-hmm. That fetal heart rate is going to be affected big time. So if mom's hypotensive all of a sudden out of nowhere, drops down with this epidural, baby's heart rate is going to drop pretty drastically and then come back whenever mom regains a normal blood pressure and regains consciousness. Your mom passes out. What are you doing? What are you going to do? What would you do if any patient passes out? What is your nursing interventions with that?
Would you administer a stimulant?
So yeah, your anesthesia provider hopefully is at the bedside and they're the ones that are usually giving the ephedrine. So yeah, you got that. But like as far as like, how are you going to position your patient? What other things would you do at the bedside?
Turn the patient on the side.
You could turn them on their side. You want to lower their head, right? So they're not going to be laying down if they're getting an epidural, depending on how the anesthesia provider positions their patient. So you want them laying down. You want, ideally, we say Trendelenburg. But if a mom just got an epidural, you're not going to want them to put them in Trendelenburg, right? Because that epidural with gravity could go right down to their chest and cause respiratory depression. So you want to put their head of the bed a little bit lower, not in Trendelenburg. And then what else are we going to do? What else are we going to give them really quickly?
Oxygen.
Fluid
Fluid? Yes,
and
fluid
oxygen.
and oxygen. Yeah. You want to put a non-rebreather mask on them, 10 liters non-rebreather. Okay. So that's what you're going to do if your mom passes out. Okay. And also, you're calling your help in because you don't want to be dealing with this on your own. You want people in the room helping you. Okay. Um, all of those interventions that I just mentioned are things that we do for fetal distress too. Okay. So we're turning the mom on the side or laying her down. We're giving her a fluid bolus. We're putting oxygen on her. So this is also correcting the respiratory depression and those the hemodynamic instability in the fetus as well. Okay. Um, and then the last ones we're going to talk about are your analgesia and so like your opioids. So there's only a couple things that are safe whenever we're in pregnancy, and some things that we need to be careful administering. So these first couple, your morphine and your fentanyl, you can administer that in pregnancy, but it does cause CNS depression and respiratory depression in moms. So you want the pulse ox on the moms, and you want to make sure that you have um, your naloxone, your antagonist available, so that if moms become super symptomatic, we can give them the reversal agent. Um, the most common one that we administer now is Nubane. That's because it has less of a respiratory effect on, excuse me, on moms and babies. It's considered to be safer in labor and delivery. So Nubane is kind of the one that we use a lot of the time. All right. So this is a really important slide for you guys to know your responsibility for pharmacological pain management interventions. You need a consent form. If your patient's getting an epidural, that is a sterile procedure. They need to sign a consent form. We are going to witness the consent. The anesthesia provider is the one that needs to obtain the consent, right? They're the ones that are doing the procedure. They need to get that consent form signed. Physicians need to be okay with the patient getting an epidural. Some physicians, when you call them about a labor, they're going to be like, okay, yeah, go ahead and admit the patient. They can have an epidural whenever they want. They can have Nubane 10 milligram, blah, 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 blah. And then other providers are going to be like, I need you to call me before I let you get them an epidural. So it kind of depends on the orders you get, but you need to have a verbal order from a provider saying they can have these pain medications. Proper documentation, right? You need to be able to document that med, document whenever your anesthesia provider is in your room, what time, when the epidural is done, all that stuff. We're scanning any meds that we're giving to prevent error, making sure that our dosage is correct, the right patient, time, dose, route, all those good things that you guys have had drilled into your brain since you started nursing school. That's still prevalent here. Have your reversal agent if necessary. We're assisting with positioning. So like I said, for that epidural, that's a big one, helping them position the patients. We're continuously monitoring a baby, right? So this is something that I've seen a lot more recently is our moms that come in that don't want their babies to be monitored. Okay. If they don't, we usually have them sign a refusal. Okay. It's like AMA. We would have them sign basically an AMA form saying, I don't want continuous monitoring. I understand the risks that are associated with this. If a patient is having any type of pain management interventions, we need to have that baby continuously monitored, okay? Because babies can be affected by these pain medications very easily, so it's important to see what's going on with them. You're following your hospital policy as far as administration, and then you're also ensuring your patient safety, okay? So like one time I had a patient who did not want to stay in bed after she got a huge dose of IV pain medication. And I basically was like, for your safety, like I need to put this bed alarm on. And I had never put a bed alarm on a labor and delivery patient before. So that was kind of a new one, but she was like very confused with the pain medicine too. So just like knowing your patient and knowing what's appropriate for them. All right, let me see if this is where I want to take a break. Yeah, so let's go ahead and take our break. Um, let's do 15 minutes, so quarter to the hour again, and then if you guys want to all come back and meet after that, let's do that, okay? So take 15 minutes. All right, let's get back into it here. Okay, so we're going to start talking about fetal heart rate tracings. So this slide is just kind of going over reasons why we're monitoring. So we're assessing fetal response, uterine activity, fetal compromise, and then we'll talk about why we do intermittent versus continuous monitoring. So fetal response, this is important because labor is a period of high stress for the baby. So one of the important things we're going to go over is what our normal heart rates and baselines look like so that we can know what is off and what is a difference. And then obviously many physiological changes are going to occur. So your fetal oxygen supply can just decrease during labor for a number of reasons. It could be because mom is having some hypertension. So there's reduced blood flow to the placenta, reduced oxygen in the maternal blood. If mom is bleeding during labor, a hemorrhage is going to reduce your fetal oxygen. Or if mom has severe anemia. Alterations too in like fetal circulation because of the compression of the umbilical cord or other abnormalities. And then if your mom is having a lot of contractions all at once, we call that hypertonia, tachysystole, which is when mom's having lots of contractions. If you're having too many of those back to back to back to back, that reduces placental blood flow and that'll reduce your mom's the oxygen that's being delivered to the baby. Okay, so there's a lot of physiological changes that can happen that can cause babies to have some distress. We monitor our uterine activity. So like, is the mom having too many contractions? Are we having none at all? Those are things that we need to know. And then any fetal compromise, so any abnormal fetal heart rate patterns, and that can be caused by fetal hypoxemia. So, which is a deficiency of oxygen in the blood. If this is uncorrected, your hypoxemia can deteriorate to severe fetal hypoxia, which is that inadequate supply of oxygen at the cellular level, which can lead to metabolic acidosis. If a baby comes out and is having like a lot of issues, most of the time we get cord gases, right? If the providers think it's indicated, if the baby's having issues or if mom is having issues during delivery. And a lot of the times if baby's in distress, it's because of metabolic acidosis. So your metabolic acidosis, this is bad because it can lead to acidemia, or is that increased amount of hydrogen in the blood. And this can cause tissue dysfunction, cellular dysfunction, or it can cause fetal demise. Okay. So metabolic acidosis is what we want to avoid. So we're wanting to avoid baby not getting oxygen during deliveries. Intermittent versus continuous monitoring. So what's important for us to know is like when is either indicated or appropriate. When in doubt, continuously monitor your baby. Okay, I very rarely will do intermittent monitoring unless it's specifically requested by the patient or there is like no risk in their pregnancy. They're in a tub and it's really hard to monitor the baby. I'll have the mom sign consent for intermittent and we'll monitor them that way. Intermittent monitoring is just when you listen to the baby's heart rate for usually about 5 minutes and then you take the mom off the monitor and then you listen again in like half an hour. Okay, so you're not having the baby continuously on the monitor, but you're still listening to the heart rate periodically. This is not an option. Like I said, if mom's getting pain management, pain interventions, if their mom is a high risk labor, if there's any issues that are happening in labor already, like you notice that the baby's having really weird things going on with the heart rate, that is not going to be a time where you're like, yeah, sure, we can intermittently monitor you. This patient's going to need to be continuously monitored if they're having anything weird happen on their tracing. All right, so before we really dive into the tracings, we want to know our normals, okay? So there is some important language that we want to talk about before we analyze these tracings. So learning fetal heart rate tracings, in my opinion, but I could be biased because I've been a labor and delivery nurse, is much easier than reading 12 lead EKGs because there's less things that can happen, okay? So you want to know baseline fetal heart rate. So your average heart rate during this is your average heart rate during a 10-minute segment. And that's excluding like if the baby's heart rate is going up or down. You want to be able to see what that baseline is, what the heart rate is continuously returning to. There must be 2 minutes of an interpretable baseline to determine the fetal heart rate. Okay. So we know our normals, right? We went over that earlier. So 110 is the lower end of a fetal heart rate that we want to see, and then 160 is a higher fetal heart rate. Something I wanted to talk about on this slide are what are some things that you guys think would cause your heart rate to be high in a baby? So I don't know if this makes it easier. Think about it like whatever's happening to mom, right, is going to ultimately be happening to your baby. So fetal tachycardia and maternal tachycardia. What could cause a mom to be tachycardic? An elevated heart rate. What would you see?
An infection?
Fever.
Yes. That's the biggest one that I want you guys to remember with fetal tachycardia is if mom has an infection. If she has mom has a high temperature, she's got an infection, that is going to cause fetal tachycardia. Other things like if your mom had her blood pressure drop and we had to give her ephedrine, okay, some medications will cause fetal tachycardia. So ephedrine is one of them. So if you have to give ephedrine to a mom after she bottomed out with her epidural, it's not uncommon to see that baby's heart rate be sustained at like 165 for a long period of time. Okay. Another medication that can cause fetal tachycardia is terbutaline. Terbutaline is a medication that we give to stop uterine contractions. Okay. Terbutaline can cause fetal tachycardia. Maternal hyperthyroidism, I mean, that kind of makes sense because with her hyperthyroidism in the mom, they're more at risk for like cardiac arrhythmias and fetal and elevated heart rates. So it's the same with a baby. With tachycardia, you're at a higher risk for fetal cardiac arrhythmias and tachycardia. Caffeine will raise baby's heart rate. Cocaine use, you can see a baby's heart rate go up with that. So those are kind of external factors that would impact fetal heart rate. Bradycardia, mostly with that one, it's interruption of the fetal oxygen supply. Okay, if your baby's heart rate's low, baby's oxygen is being interrupted. That one is a little bit less external relation. Also, sometimes you can see like other types of infections can cause bradycardia, but usually we see tachycardia if there's an active infection. And then another one with bradycardia would be like maternal hypoglycemia. So if blood sugar's low, everything is lower and depressed in mom, baby's going to have some bradycardia, lower heart rate too. Okay. Another thing that we need to know when we're looking at fetal heart rate tracings is we're assessing for what we call variability. This is our waves or fluctuations in the fetal heart rate baseline. So you have your baseline, let's say your baseline's 120, right? Heart rate is continually returning to 120. Your variability is just how often that heart rate is going either up or down from the baseline and returning to it. It's described in 4 different categories: absent, minimal, moderate, and marked. I have on the next slide some pictures that are going to go into this a lot better because it's easier sometimes to see these things. So we'll go over that. Accelerations are abrupt increases in the fetal heart rate baseline. And then I have the parameters listed. So your peak should be 15 beats a minute above your baseline, and the acceleration should last for at least 15 seconds. Okay. So when you're analyzing a strip, we need to be able to call an acceleration, and that is the definition is a 15 by 15 second accel up above the baseline. Okay. Decelerations, these can be benign or abnormal. This is what happens when a heart rate drops lower than the fetal heart rate baseline. And they're categorized as either early, late, variable, or prolonged. We're going to go into each one of these in more detail, and I have some pictures coming up here too that's going to be able to help you guys visualize it. So these are just like kind of going through the terminology to get you ready to look at these strips in more detail. So on this slide, I have here pictured for you bradycardia on the right, and then tachycardia on the left. While we're on this slide, I want to kind of also go through like how you count these boxes, okay? So you see these like solid lines here. The space between these solid lines is a minute, okay? So there's 6 boxes in between each solid line. So each box is worth 10 seconds, okay? So that's really like how you're analyzing your strip. So your space between your big solid lines is a minute. Each individual box is 10 seconds. So we're looking at like a 6-minute strip on the left. Okay. And then you have your numbers listed on the sides for you. And that is where we can tell what the fetal heart rate, the baseline is. All right. Does anyone have questions about that? Okay.
This has saved my life when I was pregnant. I had a complete uterine rupture, and my nurse, she was able to tell quickly, and she acted so quick. I still ended up hemorrhaging pretty bad, but she was so prompt. But this saved my life. I don't know what I would have done if they weren't monitoring.
Wow. That sounds really scary. I'm glad that you're okay. But yeah, fetal heart rate monitoring is huge. Like it is going to tell, it is basically really one of the only things that's going to be telling you exactly what you're looking at with your baby. You'll see some things like with mom, like with abruptions, there's obviously hemorrhaging. You're going to be able to tell like your belly's going to be really firm, like lots of those kind of things. But like with following strips, we need to look at it closely and you need to know what you're looking at because it is a really big part of monitoring your baby during labor. All right. So when we kind of talk about variability, this slide goes through and shows you, I really like these pictures, shows you kind of like the different classifications of variability and what we want. So over on this top left-hand box is absent variability. So you see how that fetal heart rate baseline, which our baseline here is like 150, you see how it's like a straight line. That is not good. We do not want that. This is like, if you see this, it's immediately you're going into the room and you're like, what is going on? You're calling your provider. Okay. So absent variability, there's no change in that fetal heart rate baseline. It stays consistently the same through all of these minutes. So that is absent variability. Minimal variability, the one on the right up in the top right corner, you see there's a little bit of activity in that fetal heart rate. So a little bit of change from that baseline. Nothing drastic, right? They're not going up and down, but you can see a little bit of variation in the fetal heart rate baseline. So we would call that minimal variability. You can, like, this can be okay because sometimes minimal variability is caused by medication administration. So if a mom gets Nubain in labor for pain management, you will see minimal variability on their tracing for a little bit, okay? It's not immediately an emergency, but if it persists for a long time, then we're gonna wanna do interventions and intervene, okay? Moderate variability, the one in the bottom left-hand side here, this is our gold standard. This is what we want. This is normal. Your normal is moderate variability. So you could see your baseline here. If we're looking at the average of where that fetal heart rate returns to, we're calling that one like 135, 140. Does that make sense to everybody? Okay. So your fetal heart rate baseline is 140, but you see how it's going up above the fetal heart rate and coming back down. And then it stays at the baseline for a little bit and then goes up and does an acceleration again. That is moderate variability, and that's what we want to see. We like that. That's normal. Marked variability is a super weird occurrence, and I honestly have not had a lot of interaction with it. We see this probably the least, but it can happen whenever, like if a baby gets really excited, if it's medications that you've given it, like if it's tachycardic and the baby's heart rate's kind of going all up and over the place because it's received a stimulant of some kind. This is just when you're having a lot of different accelerations and decelerations, and it's kind of hard to determine your baseline. Like these are really challenging to tell, like, what is my baby's baseline? What is going on here, right? So marked variability is just these really dramatic changes from accelerations to decelerations off of your fetal heart rate baseline, okay? So here I have a picture of an acceleration. So that's your 15, your peak is the highest point of your acceleration, and we want that to be at least 15 seconds above baseline. And we want the total length of the acceleration to last 15 seconds. Okay, so like this little section, I don't know if my mouse is in time with me right now, but this little section here, we have variability, right? But that's not an acceleration because it's not going up 15 seconds off baseline. It's just showing that the heart rate is having some change and some variability. But these are trends. Oops, sorry, what was that? Someone asked a question? Okay. So yeah, these pictures are really good, and they'll show you like our baseline here is about 150. So we're accelerating up, and that's good. This is a good moderate variability with the presence of accelerations. So what I kind of mentioned before was the different decelerations that we can see whenever we're having variations in our tracing. One of the first decelerations that we're going to talk about are early decelerations. So these are apparent gradual decreases in and return to the baseline of the fetal heart rate, and they happen with your contractions. Okay, these are caused by fetal head compression, and it's a normal and benign finding. Early decelerations are okay. We see them in pregnancy, we see them in labor, and we're like, all right, that's fine. We're having a couple earlies. We don't really do anything about these. This is a healthy deceleration. So your onset, the start of the deceleration, the nadir, which is our lowest point, so that peak of the lowest point of your decel, and your recovery are exactly in line with your contraction. So your contractions are the ones down here, this peak down here. So you see how it starts and peaks and ends all exactly at the same time as a contraction. That's an early decel, and that is a totally benign, okay finding. Okay. So for this, what can you guys tell me? What do you think our baseline is? We're looking at these decels, but what is our baseline?
It looks like 150, I think.
145, 150. Yeah. Yeah. Which, Professor McBride, on their exam, how close are they allowed? Like, what deviation from like the correct answer for their tracing and interpretations can they have? You know what I mean?
For, excuse me, for the purpose of the exam, they do not have to actually read the tracing. They need to understand what the words are. So, like right now, Professor Young is describing to you how this decrease mirrors the contraction. And so you might see words that say that say, the nurse observes on the fetal monitor decreases in the fetal heart rate that happen at the same time as the contraction. The priority intervention would be, what would be the priority intervention for this decel?
Isn't it normal?
Okay, right? Did she just say, she just told you guys this is a normal finding, right? This is caused by compression on the head as the baby's coming down the birth canal. So what is the intervention? Nothing. So this is one, if you have something that has a normal finding, that's something you could document the finding, reassure the parents. It's normal. Okay. So the questions that you might see on exam or a quiz are going to be more like you need to understand what it looks like, what she's showing you, so that when you see those words, you understand, like you can see it in your head and what it means, but you won't have to actually read a tracing.
All right, thank you. So moving on, we have our late decelerations. So late decels are different because they begin after the start of the uterine contraction. And then the nadir, or the lowest point, will occur after the peak of the contraction. Okay, so this decel does not normally return right away to baseline. In this tracing, it does, and it also just depends. You can have some variations in any of these decelerations a little bit. And this is caused by disruption in the fetal oxygenation. This is considered something that we would need to do interventions for a late decel. We're definitely doing our interventions. And that would be like turn your patient onto their left side, start an IV bolus, administer oxygen, contact your primary care provider, all that kind of stuff. So late decelerations is a sign of a disruption of fetal oxygenation, and we must intervene. So kind of looking at this tracing, you have a baseline here of about 130. This is where your decel starts, and you can line it up with your contraction and see that it starts at the end of your contraction. The lowest point is occurring after your contraction, and then it returns up to your baseline. And you have three of those decelerations right in a row. So this is something we definitely would be going to the bedside and doing our interventions with. So variables is an abrupt drop. I kind of describe it, and it looks like a V. So V for variable. Okay, that's the best way to kind of remember this. They're a really abrupt decrease in the fetal heart rate below the baseline. So this is at least 15 beats per minute or below the baseline, and it lasts at least 15 seconds, and then it returns to the baseline in less than 2 minutes from the time of onset. So this is caused by cord compression, and it can happen with or without your contractions. So whenever you see UCs, that means uterine contractions for the abbreviations that I'm putting. So an occasional variable can be clinically insignificant, right? So if we see one variable randomly throughout a tracing, and your tracing has really good accelerations, moderate variability, and you have an abrupt variable, that is okay every now and then, but we don't want it to be reoccurrent, because if it continuously happens, that can indicate a disruption of fetal oxygenation. And at that point, interventions are going to have to happen to stop these, okay? And that could be like our position changes, giving a bolus, turning your patients, getting them on hands and knees, kind of seeing whatever is going to kind of throw this baby's out of this pattern and relieve some of that pressure on the umbilical cord. That's our priority. Come on, PowerPoint. There we go. All right. So our last one we're going to talk about is a prolonged deceleration. Oh my goodness, I just hate looking at this. This makes me cringe inside. It is a decrease in the fetal heart rate of at least 15 beats and below the fetal heart baseline, and it lasts longer than 2 minutes, but hopefully less than 10 minutes. So this occurs whenever the mechanisms responsible for late or variable decelerations last for an extended period, okay? So you're having that cord compression or that interruption in fetal oxygenation for a long time. This is what's going to happen. Your baby's going to be like, I don't know what the heck's going on, but I don't like it, and you're going to know because I'm going to look like this. This is an emergency. Like, you should be running into your patient's room and calling other people to run into your patient's room to do your interventions, okay? So this is that prolonged disruption in fetal oxygenation. So looking at this picture, we see our baseline is about 150, and this heart rate drops all the way down at the lowest point to 80, and then it comes back up. And this lasts for, if we count these boxes, 1, 2, 3, 4, almost 5 minutes. Okay, so that baby lost a lot of its oxygen reserves here. Okay, so we need to get in there. We need to change the mom's position, give her some fluid, and get this baby out of here, out of this right here. Okay, because this is definitely an emergency and is a terrible thing to see when you're working. All right, so before we get into our interventions, and I have a really nice picture on one of the other slides for us, what causes some disruption of our oxygen between moms and babies? So that uterine tachysystole that I was talking about when we first started talking about the tracing. So mom's having a lot of contractions. Like, we're having contractions that are like every minute apart. There is barely any break between. if that mom is having that compression, that squeeze on the baby, and that compression of the cord and the placenta and everything, is that baby going to get enough oxygen in between those contractions if it's only for short amount of time? No. So it's going to run through its reserves, and you're going to start seeing things like late decelerations or prolonged decelerations. If mom is hypotensive, like with that epidural or spinal anesthesia placement, like if mom's blood pressure drops, that's going to disrupt the oxygen to the baby. Okay. Sometimes with the placenta previa, you can see a little bit of disruption of oxygen transfer between the mom and baby, just because of where the placenta is and the anatomy of like how the placenta is being oxygenated by mom. Like I said, hypertensive disorders, post-term gestation. So if a mom is coming in and she's 42 weeks, her placenta is tired. That is a tired placenta. It is not perfusing correctly. It's not getting as much oxygen to the baby because it's just worn out. It's been in there for too long. It's time for this baby to come out. So you're going to see some of those weird decelerations with a patient like this. And then any like fetal growth restriction, so like IUGR, you're going to see some disruption with oxygenation as well. Maternal diabetes is going to disrupt all of these mechanisms and make it harder for baby to get oxygen. And then also like if there's choreo, so any like intra-amniotic infection. So if the amniotic fluid is infected, or if mom has an infection, it can cause some weird stuff with baby to happen too. The other week, actually, I had a mom in labor and the baby's heart rate was like tachycardic, and she went pretty quickly. And I suspected that she either had like choreo or something going on. Well, we ended up transferring the baby, and the baby tested positive for the flu, unfortunately. So baby was in the NICU. But it kind of like when you know these things, you go back on your fetal tracing and you're like, okay, what I'm seeing here right now makes sense, seeing at what the baby looks like whenever they come out following delivery. So this page talks a lot about our interventions for the late recurrent variables and prolonged decelerations. Okay. So one of the first things, if you're running an induction of labor, okay, and your doc tells you, let's give the patient Pitocin through their IV, which Pitocin causes moms to have more contractions, more strong, frequent contractions, and your baby starts having decelerations, starts having late decelerations, are we going to keep running oxytocin in that IV? No, we're shutting that thing off. That is the first thing you should do. Okay. So if you have to do any interventions at all, you better not have your pit running, right? So if you're documenting in the chart, like IV fluid bolus initiated, oxygen mask applied, 10 liters via non-rebreather mask, and they see that your pit is still running, that's like, why are you running pit if you're doing all these other things? So that is number one. We're assisting the mom to that sideline left lateral position, because the perfusion to the placenta is increased when mom is on her left side. Okay. So that is the best way to get and deliver oxygen to the baby. However, if mom is having those variable decelerations, because of cord compression, one of the best positions to put mom in, if not on the left side, is on her hands and knees, because that's relieving pressure on the umbilical cord, and it's not compressing as tight, as hard onto the umbilical cord. So it's going to relieve some pressure on that and decrease those decelerations. We're correcting maternal hypotension if that's the root cause of these problems. Increasing your maintenance fluid. We're going to be palpating the uterus to assess for any tachysystole, or if you palpate that uterus and it is rock hard and she is not having contractions and it's staying that way, and the mom is like jumping out of the bed in pain by you just touching her belly, she's having an abruption, and that is an emergency, and we need to call in the surgical team. Okay. If you're doing any of these interventions, you need to let your provider know. Okay. Like, and it might, when you're on night shift, you might not want to call and wake up your doctor to tell them, like, hey, I started an IV bolus because this patient was having decelerations, but too bad. So like, too bad, doctor, whoever, I'm going to wake you up and tell you, because if I'm doing interventions to correct a fetal heart rate tracing, your provider should know about it. If you're unable to assess the baby's heart rate or assess the contraction pattern effectively, we need to consider internal fetal monitors. So that would be like a fetal scalp electrode or an intrauterine pressure catheter, an IUPC, which we're going to talk about that in a couple of slides, okay? And then we're going to assist with preparation for birth if the decelerations can't be corrected, right? So if they're recurrent and baby's looking like they're not getting any better, we might have to prepare for a C-section. So this little mnemonic here is awesome. I'm sure you guys have maybe heard of it. Veal Chop Mine. It kind of goes through like, what is your pattern? What's happening? What the cause would be for that decel, and then what your management is. Okay. So you see you're having a variable that's caused by cord compression. You're repositioning your patient. If you're having an early deceleration, that's head compression. And we're just seeing how the labor is doing and letting the mom labor. If you're having an acceleration, that's great. We love those. We're not doing anything. And if you're having a late deceleration, that's placental insufficiency or fetal, like the fetus isn't getting enough oxygen. So we're going to start interventions. Okay. So we talked about the baseline of fetal heart rate and everything. Now we're going to kind of go over contractions and how we measure contractions. There's some important language for us to know whenever we're just documenting and talking about these. So we measure our intensity, our duration, our frequency, and our resting tone. Intensity is usually described as mild, moderate, or strong, and this is palpated by the bedside nurse. Okay. And this is when you're like actively pushing on the mom's belly when she's having a contraction to see how strong it is. The best way I can describe mild, moderate, or strong would be if you touch your finger to your nose, that is a mild contraction. That's what that would feel like. If you touch your finger to your chin, that would be a moderate contraction. And then if you're touching your finger to your forehead, that is a strong contraction. That's kind of how you can tell the difference whenever you're palpating. You cannot tell the intensity of a contraction on the tracing unless the patient has an internal monitor. Okay. It doesn't matter if the contraction spikes all the way up to the top of your screen and down. If you don't have an internal monitor put on this patient, you won't be able to accurately know the intensity. Okay. Your duration of your contraction is measured in seconds. This is how long your contraction lasts. It's measured from the beginning to the end of the contraction. We'll look at a strip and I'll show you. But you're counting those little boxes, okay? And then your frequency is how often your contractions are occurring. This is measured in minutes. So she's contracting every 3 to 5 minutes, okay? That's a common thing to say or to chart. You're measuring the start of one contraction until the beginning of the next contraction. So you're counting the time in between, okay? And then your resting tone is the measurement of the belly, like how the belly feels in between contraction. And this should be described as soft or hard, and it's palpated by the nurse. And you want it to be soft. If your abdomen is hard in between your contractions, that is when we're worried about like an abruption or something else, or a hemorrhage or something else is going on with the mom. So we always want our tone in between contractions to be soft. All right, so kind of looking at this picture is really awesome. So like I said, each little dark line in between here is your is a minute. So from the start of one contraction to the start of the next contraction is your frequency. So these are every, let's see, like 3 minutes apart. Your contraction here is 3 minutes apart, but the start of this contraction to the start of this contraction is a little bit closer together. So that would be almost like every 2 minutes apart. Okay. Your duration right here is kind of detailed for you, and that is the amount of time that how long the contraction lasts. So we're going to count the little boxes from the start of one contraction to the end of the same contraction. So this contraction is 1, 2, 3, 4, 5, 6, 60 seconds long. Okay. And then your intensity is just measured by like how strong your contraction is, which it's really hard to tell, like I said, if you don't have an internal monitor and you're not calculating MVUs, which we'll kind of talk about that a little bit here, but it's not as accurate when you don't have internal monitors in. Okay. So this here I basically copied from the table in your textbook, and it is a category 1 fetal heart rate tracing. Our fetal heart rates are broken into 3 categories, categories 1 through 3. Category 1 is your normal. That's what you want to see. So all of these parameters on your screen here is what we want to see when we're analyzing a fetal heart rate tracing. Okay, your baseline is between 110 to 160. You have moderate variability. You have no decelerations. You have accelerate. Oop, that's what should be. Oh, sorry. Early decelerations can either be present or absent. Your late or variable decelerations are absent. And then with your accels, they're either present or absent. So you do not have to have giant accelerations for it to be a category 1 tracing. We just want to see that moderate variability is a good indicator. And then your normal uterine activity, usually your contractions are every 2 to 5 minutes, 2 to 5 per 10 minutes. And then they last usually 45 to 80 seconds. And then the strength, I have listed here what that we would need for an internal. And then your resting tone should be soft, okay? And then there should be at least a minute or more in between each contraction, okay? So I have a little link here for a practice game. Right now we're kind of short on time and I want to get to the other couple slides that I have. But tomorrow I have a review session at 10 for the exam, and I was going to do this with whoever comes to that. So if we have time at the end, we can do some of these too. But this is a good thing for you guys to use to practice on your own as well. All right, so the types of monitoring, we obviously have an external monitor, which you have your ultrasound and your TOCO, and the ultrasound is what measures the fetal heart rate, and then your TOCO is the transducer that monitors your contractions. Okay, I have a picture in that top right. This is the external monitors. Internal monitoring is that fetal spinal electrode. That is something that nurses can place. It's just a little electrode that kind of you like screw into part of the baby's skull. And that is an internal monitor that gives you an accurate reading of the baby's heart rate. Okay. For nursing interventions with an internal monitor, you want to monitor that baby's FSE site after delivery to make sure that it doesn't get infected. Okay. Because it is like a needle, basically, like it's an open injury on the baby's scalp. But it's really small and it doesn't do damage. Nurses have to be checked off on this because the biggest thing is you do not want to place an FSE on a baby's suture, right? Because that is basically putting that in the baby's brain. We do not want to do that. We want to put the FSE on the hard parts, on the bones of the baby's scalp. So nurses usually have to be checked off on this if they're going to be doing this at the bedside. And then at some hospitals, like if you have residents and stuff, you're not really usually doing FSEs. They're usually the ones that are doing it for you, or the providers will. But at the LDRPs that I work at, the nurses do FSEs because we don't have doctors in-house. So we're doing them. Intrauterine pressure catheter, that's a whole different story. Nurses are not allowed to put these in. And that's because it is a catheter that goes up and lays next to the baby. But what we need to watch is that it can cause uterine abruption. Sometimes it's like if it's being placed too firmly, or depending on where you set this, it's firm enough that it can puncture things. So that's why providers have to do this. Nurses don't do these. So it is a catheter that goes up and lies right by baby, and it is it most accurately measures the strength of the contraction via Montevideo units. And then also the other thing that we need to know about IUPCs is these can be used for amnio infusions. So for a patient who has oligohydramnios who's been ruptured for 12 hours and that baby is having these crazy variable decelerations or having like lates, something that providers might try is to insert more fluid into the cavity to kind of put some more cushion around the baby and relieve some of that compression that they're feeling. Okay, that's something that some providers will do to try and avoid a C-section or any other type of intensive interventions. So some other things that you can do to assess like fetal well-being while we're in labor is fetal scalp stimulation. This is not as common anymore. There's also been some recent evidence that's come out that providers shouldn't be relying on this to show like that the babies are doing okay. Basically, what happens is like a provider would perform a vaginal exam or a nurse, and you kind of just like tickle the top of the baby's head. And whenever you are watching a monitor, when you do this, a baby should have an acceleration. So a baby's heart rate will go up. They'll be like, oh, hey, just them saying like, hey, I feel you. I can tell that that's happening. Um, like I said, it's not really medically advised as much anymore just because of like it's just something that they're saying like not to rely super heavily on. So this is the next one is obtaining cord blood post delivery, and acid-base determination. So like cord gases, right? You obtain the cord gases to see like is baby in metabolic acidosis at delivery? What other kind of things happened during delivery that could have been caused by X, Y, and Z? So you can get these cord gases to kind of determine what was going on with your baby during labor. Like I kind of talked about a little bit, that amnio infusion that we do using the intrauterine pressure catheter. It usually is infusion of like LR or normal saline into the uterine cavity. And like I said, it's adding additional fluid, which can relieve some umbilical cord compression if the fetus is showing some signs of respiratory distress. And the other last thing that we can do, so if your mom is having a lot of contractions, like they're tachysystolic, having like one contraction every minute, we can administer tocolytic therapy, which is terbutaline, which is that medication I was telling you guys about that will decrease contractions or slow down contractions. This also we have to be careful with though, because it can have some effect on the fetal heart rate, and it also sometimes can cause some adverse rear effects with the contraction pattern as well. All right, let's see what we got left. So this is going to go a little bit in more detail towards the stages of labor. So we'll get through this a little bit quicker here. But the first stage of labor begins with the onset of regular contractions and ends with complete cervical dilation. I have here defined for you the latent and active phases, and a nice picture over here that kind of talks about like what we're teaching our patients on when we know that they're in the first stages of labor. Interventions, whenever a patient comes in and they're like, hey, I'm in labor, we're triaging the patient, right? So we're going to interview them. We're confirming if their water broke by using either nitrazine paper or a Fern test, which is when a doctor gets a sample of the fluid in the vaginal canal and looks at it under a microscope, or an AmniSure and Actin Prom. That's a little swab that we put in the vaginal canal that tests for the presence of amniotic fluid. So we're ruling out if the patient's water has broke or not. We're performing a vaginal exam if it's appropriate. If you know the patient has a placenta previa, like that placenta is what the presenting part is on the cervix, are we going to be putting our fingers up there and trying to feel whether if she's dilated or not? Definitely not, because we don't want to be poking that placenta and risk like rupturing anything or doing anything damaging. If the patient brings in a birth plan, we're reviewing that. We're putting the patient on the monitor, reviewing their history, assessing vitals. Obtain a urine sample if it's indicated. Some hospitals require a urine sample on admission. Others will only do it like if the patient has hypertension or is at risk for a UTI or something like that. Check for any leaking of fluid or bloody show. Ensure that the patient is not bleeding profusely. If they are, that is an emergency and we need a provider at the bedside. And then if they're being admitted, we're doing all of our admission things. We're putting in an IV, moving them to a delivery room. We're going to start those interventions of the pharmacologic or non-pharmacologic interventions. Help them with fluid intake, whether that's intravenous or oral. Help them with elimination, support them in labor, doing all the positions. Okay, so the first stage of labor is when the nursing is like really important, because this is the main part of the support system and they're going to need us at the bedside. Second stage is when the baby is born. It begins with full dilation and complete effacement and ends with the birth of the baby. So there are it can be divided into two phases, the latent phase, which is laboring down. So this is what happens when like a mom is complete, but she's resting and there's relative calm before she begins pushing and having that urge to push. Her urge to push might be there, but it's not urgent to the point that she's like, I have to, like, I'm going to do it anyway, whether you tell me not to or not. And then her active pushing phase. So this is a Ferguson reflex, which I would know that reflex and what that means. This is also called the fetal ejection reflex, and it's just that strong urge to push where the patient like physically cannot stop and they have to. Okay. So for our nursing interventions in this stage, we're performing a vaginal exam to accurately tell where the patient is at that time. We're notifying the doc, making sure they know, like, hey, your patient's 10 centimeters. You probably should get up here. We're still monitoring that patient. We're preparing the warmer to receive the infant. Okay, so you're getting all your resuscitation equipment ready, especially like this isn't always pertinent because at some hospitals, there's other staff that come for delivery of baby. But like at a smaller LDRP like us, like we're the mom's nurse and we also are going to help receive the baby and take care of the baby at delivery. So have your extra people there, have your room set up. And then we're helping our mom with breathing techniques and our position changes. And then if mom wants to and is open to it, we're coaching her through pushing. Okay, we're telling her how to more effectively push. So that was like grab your behind your legs with your arms and bring your legs if they're in lithotomy, and like how to breathe and how to count and helping them with that, because if this is a first time mom, she doesn't know what she's doing. She's gonna need some direction, right? So that's where we come in. Our third stage of labor is from the birth of the baby until your delivery of your placenta. So this can be like a 2-minute stretch. It can be a 15 or longer minute stretch. You're helping the mom push for the placenta. She might need to push a little for the placenta. We're assisting the provider on collecting cord blood and cord gases. We're providing pain relief measures. So if the providers are doing like a perineal repair, or having to cut an episiotomy, like we're helping them with this. Assist the infant into skin-to-skin contact. So kangaroo care or the golden hour, that first hour where we want baby skin-to-skin with mom. And we're providing time with the parents to bond with the infant independently if we can, okay? We want to also advocate for delayed cord clamping. Most providers are doing this anyways, but as a nurse, sometimes some providers, you may have to tell them, hey, like the cord's not done pulsating, the cord's still, the cord's not white yet, you know, because we want that baby to still be receiving that blood. And it also is just very beneficial in a lot of different ways. And then finally we have baby. Yep. Oh, what is happening? There we go. The fourth stage of labor, which begins with the expulsion of the placenta and lasts until the mother is out of the recovery period. So you're assessing mom's vitals every 15 minutes for the first 2 hours or per hospital policy. Assist with the perineal repair if needed, help empty the mom's bladder if needed, because a full bladder is going to push up on your uterus and it's not going to allow the uterus to fully contract and clamp down. Okay. So that can increase their bleeding, and we want to avoid that. We're looking at their lochia, so the amount, location, and odor of that vaginal discharge. And we're doing the fundal assessments and massage to ensure that that uterus stays contracted and stays nice and firm, right? Prevent bleeding. So this mnemonic over on the side here is just kind of showing you the things that as bedside nurses we need to be assessing in that immediate postpartum period. This, I have a diagram here on how to provide fundal massage. So you're going to be like kind of cupping the fundus above the symphysis pubis, and then you're kind of rubbing it and squeezing it. Anyone that has had a baby knows that the nurses are really mean and are really strong at doing this immediately after delivery. We are not your best friend when we're doing these. But that's just to help get out any extra clots, making sure there's no retained placenta or retained product up in the uterus that's preventing mom's uterus from fully contracting and clamping down and reducing blood. And then over here, I have a diagram that shows where your fundal height is going to be. So immediately after delivery, it actually is a little bit lower. It's like -2 centimeters from your umbilicus. And then it'll get a little bit bigger and then it'll slowly go down again. Okay. Next week, we're going to talk about the postpartum assessment in a lot greater detail. So that'll be a little bit better understood at that point. So, and then the last thing that we need to do as nurses is promote maternal comfort and infant bonding. So you're getting your mom something to eat. If she's been in labor for 24 plus hours, she's going to be starving because we've had her on clear liquids. So you're not going to get her up to the bathroom if she hasn't had any food, because you're going to have her pass out on you, and that's just the worst. You'll help her up to the bathroom after she's eaten. Monitor mom's emotions and provide a lot of education as far as postpartum depression and baby blues. Okay, this is a huge thing that we need to educate moms on. Even if you think like, oh, she doesn't have any history of anxiety or depression, that does not matter. We need to be telling every single mom about like, hey, if you start feeling like you don't want to take care of your baby or you can't even get yourself up in the morning, like that is not normal. And we need to let your provider know that because that's an emergency. We're encouraging bonding with the baby. So skin to skin with mom and the support person. Okay. It doesn't have to just be skin to skin with mom. If mom is having a really extensive perineal repair or she is not feeling well, like her blood pressure is through the roof and we're doing a bunch of stuff with her, like skin to skin can be done with the support person who is in the room. Okay. Keep getting breastfeeding going right away. Keep mom and baby warm, dim our lights down, have as many people in the room as the mom wants. Okay. That's going to vary per person. Some people have 25 people in the room. Some people just want their partner in the room. And then maintain cultural considerations. That kind of goes under that same concept of we need to be honoring mom's preferences, honoring what she wants, and maintaining that. Okay. So that is the last slide that I have. I want to go back up here and show you guys this practice site because I think it's really awesome, at least to practice fetal heart rate tracings. I thought I made this a link, but I guess I didn't. So this is the practice site, and this is going to be really awesome for you guys if you're wanting to get some more stuff done with tracings. So like here you can pick the collection. I don't really know if there's a difference in the collections. You're just going to have to kind of play with it here, but you hit start and then you pick that you're like you're a registered nurse. Hit start. And then it'll give you a tracing. And then you go through down here and you pick based on what you think. So we'll do this one together here really quick. So is our baseline normal? Like what's our baseline?
Normal.
Yeah, that's normal. Do we have good variability?
Yeah.
Yeah, so that would be moderate. Do you guys see accelerations in the tracing?
No.
Right, so well, I would say we had a couple. Let me see. So yeah, we have some here. Like this would be an acceleration. Potentially. Yeah, see there's one, I believe. Let's see. I might be wrong. Yeah, I was wrong. All right, so they're absent, which is fine. You can have a category 1 tracing and have it still not have accelerations. Are we having any decelerations?
There's one, isn't there, right there?
This one, is this what you're talking about?
Yeah, there's a D cell. It looks like right after
I wouldn't say that as a decel. Let's see. Yeah, we don't have any D cells in this tracing because we don't have anything that lasts longer than 15 seconds off the baseline. So because we have all of these characteristics, this would be a category 1. This would be a normal strip. This is okay. And then what about our contractions? Like how frequent are our contractions?
Every
They're like happening every minute to 2 minutes. And then they kind of space a little. So let's see, we got 2. So I would say for this, like I would personally would say we're having too many, right? Because we're just having them kind of back to back. Like one ends and then the next one is starting. So it's not giving us a lot of time for our baby to recover. Okay, so go through this and practice with these if you want. I'm going to be doing this in my review session. We're unfortunately out of time. So thank you guys for, let me see.
I would like for the young lady that was calling me all those names to stay after so we could talk.
January, if you
Because
want
she
to
owes me
stay,
an apology.
yeah, if you want to stay after, we
Yeah,
can,
she needs to stay too.
yeah, we'll definitely meet. Um, but we'll let everybody else go. I have a review session tomorrow morning, and it's going to be 10 a.m. Eastern. Okay, so whoever can make it, please come. If you can't make mine, definitely look at the schedule and try and get to one of the other ones because that's going to be really helpful for you guys studying for exam 1. Okay, and then I will be releasing the Welcome to Week 4 on Saturday morning. Okay.
Okay.
Miss Young, can I stay after to ask you a question?
Yeah, yeah. If anybody else has questions, you feel
Yeah,
free.
because her information was all wrong. She got the wrong name. But I can give her the name that she needs because she calling the wrong person out their name.
Oh, okay. Yeah, let's talk about it here once everybody is gone.
So go ahead and stop your recording before we discuss the private stuff.